In this video, we will explore the internal configuration of the heart, focusing on its chambers, valves, orifices, and the key structures that ensure the proper direction and flow of blood. Understanding these internal features is essential for grasping how the heart functions as a highly efficient pump. To do so, we will start by detailing the interventricular septum, followed by the interatrial septum, the orifices at the base of the heart, and the heart's chambers. Some key clinical notes and applications. And finally, a conclusion. Let's start with the interventricular septum. The interventricular septum extends from the anterior wall to the inferior wall of the heart. It is triangular in shape. Its base faces the atria, where it continues with the interatrial septum. Its apex corresponds to the apex of the heart. Its right surface belongs to the right ventricle, and its left surface is concave, facing left and downward. The interventricular septum has two structural parts. A thick muscular part that gives rise on the right to the pillars of the septal leaflet of the tricuspid valve, and a thin membranous part, called the pars membranacea, located at the base of the interventricular septum, in close proximity to the interatrial septum, opposite the posterolateral right part of the aortic orifice. Its left surface corresponds to the ventricle, and its right surface provides the insertion for the septal leaflet of the tricuspid valve. The interatrial septum is a thin membrane that separates the two atria from each other and has two surfaces: a right surface and a left surface. In the next chapter of our video, we will detail the orifices at the base of the heart. There are two main types of orifices located at the base of the heart: atrioventricular and arterial. Atrioventricular orifices are the left atrioventricular orifice, also known as the bicuspid or mitral valve, and the right atrioventricular orifice, guarded by the tricuspid valve. The arterial orifices are the aortic orifice, which opens into the ascending aorta, and the pulmonary orifice, leading into the pulmonary trunk. Then we will explore the projection of these orifices on the anterior thoracic wall. Since these orifices correspond to specific locations on the anterior thoracic wall, allowing clinicians to estimate their position during physical examination or imaging. Let's start with the atrioventricular orifices. Each of them is equipped with a valvular apparatus called an atrioventricular valve. These valves have the shape of a membranous funnel, attached by its base to the edge of the atrioventricular orifice, and projecting into the ventricular cavity. They are divided into several leaflets by deep indentations. Each leaflet presents a smooth axial surface facing the atrium, a parietal, peripheral, surface oriented toward the ventricle, made uneven by the attachment of the chordae tendineae. Chordae tendineae are classified into first-order, second-order, and third-order types. Each leaflet also has adherent border joined to the border of the atrioventricular orifice, implanted on the fibrous ring, and a notched-free border. The schematic illustration shows the tendinous and muscular structures of the heart, specifically highlighting the chordae tendineae and their connections between the papillary muscles and the valve leaflets. According to Kamina's classification, the chordae are divided into three types. Chordae tendineae of the first order extend from the papillary muscles and insert directly into the free margin of the valve leaflets, playing a key role in valve closure. Chordae tendineae of the second order insert into the ventricular face of the leaflets, providing additional support to the valve structure. And chordae tendineae of the third order attach not to the leaflets but to the ventricular wall or the base of the papillary muscles, contributing to the stability of the subvalvular apparatus. The image effectively illustrates the spatial arrangement of these chordae, showing how they coordinate the function of the atrioventricular valve during the cardiac cycle. The left atrioventricular orifice occupies the inferior part of the base of the heart. It is located to the left of the tricuspid orifice. Around its border, which measures 110 mm in men and 90 mm in women, is attached the mitral valve, which has two cusps or leaflets, a right arch leaflet and a left small leaflet, to which are connected the papillary muscles of the left ventricle. The chordae tendineae from the anterior papillary muscle attach to the upper halves of both leaflets, and the chordae tendineae from the posterior papillary muscle attach to the lower halves of both leaflets. The right atrioventricular orifice is a valvular apparatus located at the inferior part of the base of the right ventricle. It connects the right ventricle with the right atrium. Its circumference is 120 mm in men and 105 mm in women. The tricuspid valve is divided by 3 notches into 3 cusps or triangular leaflets, anterior, inferior, and septal. Attached to these leaflets are the papillary muscles of the right ventricle. The septal leaflet receives chordae tendineae from the conal papillary muscle and the inferior papillary muscle. The anterior leaflet receives chordae from the anterior papillary muscle and the conal papillary muscle. The inferior leaflet receives chordae from both the inferior and anterior papillary muscles. Moving to the arterial orifices of the heart. Each of them is equipped with 3 leaflets, the semilunar valves. These valves are thin membranous folds that form pocket-like cavities with the arterial wall to which they are attached. Each leaflet can be recognized by a superior or parietal surface, which is concave, an inferior or axial surface, which is convex, an adherent concave border by which the valve attaches to the wall, and a free horizontal border. In the middle of this border, there is a small bulge formed by a fibrous nodule, called the nodule of Aranches for the aortic valves, and the nodule of Morgagni for those of the pulmonary orifice. There are no chordae tendineae for the semilunar valves. The aortic orifice occupies the upper part of the base of the heart. It is more anterior than the mitral orifice and located behind the pulmonary orifice. Around its border, which measures on average 25 mm, are attached the 3 sigmoid valves, oriented opposite to their counterparts in the pulmonary artery, and distinguished as posterior, left anterior, and right anterior. The pulmonary orifice occupies the anterosuperior part of the base of the heart, and follows the pulmonary infundibulum. It is located above, in front of, and to the left of the tricuspid orifice. It is circular and measures approximately 25 mm in diameter. It has 3 leaflets: anterior, right posterior, and left posterior. When it comes to the projection of the orifices of the base of the heart on the anterior thoracic wall, the sounds produced by the different valves during their closure are best heard at the point where the blood flow from these valves comes closest to the thoracic wall, as follows. The aortic valve is best heard at the level of the second right chondrosternal junction. The pulmonary valve is best heard at the level of the left sternal border of the second intercostal space. The mitral valve is best heard at the level of the 5th left intercostal space, within the midclavicular line. The tricuspid valve is best heard at the level of the 5th right chondrosternal junction. Let's delve now into the cardiac chambers. The heart has 4 chambers. 2 upper chambers called the atria, right and left, separated by the interatrial septum. And 2 lower chambers called the ventricles, also right and left, separated by both the membranous and muscular portions of the interventricular septum. The right atrium receives deoxygenated blood from the body and passes it to the right ventricle, which pumps it to the lungs. Oxygen-rich blood returns to the left atrium, then moves into the left ventricle, the strongest chamber, which sends it out to the entire body. This coordinated flow ensures efficient circulation. The atria have thinner walls than the ventricles, and their shape is cubic. The right atria is ovoid with a vertical major axis. In front of its lateral wall, the orifice of the right atrium is visible. This is a cavity whose walls are raised by numerous fleshy columns of the 2nd and 3rd orders. The septal wall is formed by the interatrial septum. It presents a rounded depression, the fossa ovalis, limited by a prominent ring, interrupted at the bottom and posteriorly, known as the Vuisson's ring. The superior wall presents the non-valvular orifice of the superior vena cava. It is circular, with a diameter of approximately 2 cm. The inferior wall is excavated with 2 orifices. Posteriorly, the orifice of the inferior vena cava, 3 cm in diameter, located at the junction of the inferior and posterior walls, with an anterior-inferior edge that presents a lamellar protrusion, the Eustachian valve. And anteriorly and medially, the orifice of the coronary sinus, which has a diameter of 12 mm, and is limited anteriorly and inferiorly by a thin fold called the Thebasian valve. And the posterior wall is smooth, presenting a transverse protrusion between the orifices of the two caval veins, known as the lower tubercle. The anterior wall corresponds to the right atrioventricular orifice or tricuspid valve. Meanwhile, the left atrium is ovoidal with a long transverse axis. The lateral wall is smooth and presents, in front, at the junction with the anterior wall, the orifice of the left auricle. The medial wall is formed by the interatrial septum. Often, a projection can be seen here, corresponding to the fossa ovalis of the right atrium, and it is limited in front by a membranous crescent, the semilunar fold. The anterior wall corresponds to the left atrioventricular or mitral orifice. The posterior wall is perforated by the four rounded ostia of the pulmonary veins. And the superior and inferior walls are smooth and narrow. Let's detail now the two ventricles of the heart. The right ventricle has the of a triangular pyramid with three walls, a base, and an apex. The anterior wall corresponds to the sternocostal surface of the heart. The inferior wall corresponds to the diaphragmatic surface. The septal wall is represented by the interventricular septum. The base contains the right atrioventricular orifice and the pulmonary artery orifice. The right ventricular cavity extends upwards and to the left in the form of a funnel, whose truncated segment corresponding to the pulmonary orifice. This extension, called the infundibulum, shows on its medial wall an oval-shaped ridge called the spur of Wolf. The left ventricle's walls are much thicker than those of the right ventricle. It has the shape of a cone flattened transversely, so that one can distinguish a septal wall, a base, and an apex. The base of the ventricle has two openings. The left atrioventricular orifice where on its two leaflets terminate the tendinous cords on the anterior papillary muscle and the posterior papillary muscle. And the aortic orifice. The septal leaflet of the mitral orifice, the muscular pillars, and the tendinous cords form a partition that divides the left ventricle into two parts. The left side forms the venous or inflow chamber and corresponds to the mitral orifice. And the right side forms the arterial or outflow chamber. This extends into a conical structure that leads to the aortic orifice. The wall of the ventricles are lined with muscular projections called trabeculae carneae, which are classified into three types. First-order trabeculae, also known as papillary muscles, conical in shape and attached by their base to the ventricular wall. From their apex arise small tendinous cords that insert into the edges and parietal surface of the atrioventricular valve. Based on their insertion points, the chordae tendineae are divided into three categories. First-order chordae attach to the adherent margin of the valve. Second-order chordae insert on the parietal surface. And third-order chordae fix onto the free edge. Second-order trabeculae carneae are anchored to the ventricular wall at both ends and remain free along the rest of their length. And third-order trabeculae carneae are fully attached to the wall along their entire length. Finally, let's explore some clinical notes and applications. Mitral valve prolapse occurs when the valve leaflets bulge into the left atrium during systole. The chordae tendineae prevent valve eversion during ventricular contraction, maintaining proper closure. However, chordae rupture leads to mitral or tricuspid regurgitation, as the valve fails to seal completely, allowing blood to flow backward into the atrium. The calcification of the aortic valve leaflets prevents their complete opening, leading to an obstruction of normal blood flow from the heart. This condition, known as aortic stenosis, forces the left ventricle to work harder to pump blood through the narrowed valve, which can eventually lead to ventricular hypertrophy and reduced cardiac efficiency. Cardiac output refers to the volume of blood ejected by the ventricle per minute. It is a key indicator of heart function and is calculated by multiplying stroke volume, the amount of blood pumped with each beat, by the heart rate. This measurement reflects how efficiently the heart is supplying oxygenated blood to meet the body's needs. The average cardiac output at rest is about 5.6 liters per minute in males and around 4.9 liters per minute in females. Blood pressure corresponds to the force exerted on blood vessels. It results from the blood flow generated by the heart contractions and the resistance encountered as blood moves through a closed vessel. Blood pressure is used to assess normal cardiovascular function and is a key indicator of circulatory health. The average systolic pressure is 120 mm of mercury, while the average diastolic pressure ranges from 70 to 80 mm of mercury. To conclude, the heart's internal configuration reflects its complex yet highly organized structure, ensuring efficient unidirectional blood flow.